Good afternoon, everyone. Welcome to today's webinar on headaches in MS. We're lucky enough today to have Dr. Jason Ray, who is a neurologist and a headache subspecialist from Alfred Health, Austin Health and Monash University. He's the guru of headaches, so we were definitely lucky to get him, and should be in for a good half an hour to an hour. So I would like to begin by acknowledging the traditional custodians of the land we are meeting on today and pay my respects to their elders past, present and emerging. I also acknowledge my gratitude that we share this land today, my sorrow for the cost of that sharing, and the hope and belief that we can move together to a place of equity, justice and partnership. So an introduction on Dr. Jason Ray. He's an academic neurologist and a headache subspecialist working at the Alfred and Austin hospitals in Melbourne. And he's also the deputy head, he's the deputy head of the headache service at Alfred Health and an early career researcher at Monash University with 20 peer-reviewed publications, several book chapters, and is engaged in both commercial and investigator-initiated drug trials. He has a passion for the education of health professionals in headache medicine and regularly lectures for medical students and doctors in training. So he's got a lot on his plate.
Thank you very much. It's a real privilege to be invited to have a discussion with all of you with regards to headaches in multiple sclerosis. It's a wonderfully broad topic, so rather than try and go into horrible detail with regards to the different pathologies and different sorts of conditions, I thought I'd try and introduce a couple of headache disorders that are most associated with multiple sclerosis and a brief description about them, as well as a couple of the common questions which I sometimes will get asked as a neurologist who focuses on headache disorders, and then leave plenty of time really at the end for the questions that are most relevant for you. So by way of introduction, I've been asked to put in a couple of questions, so I thought we'd start off with this one. So which is the most common disorder worldwide? So asthma, diabetes, migraine, epilepsy, multiple sclerosis. So national action plans for asthma, diabetes, increasingly common in our society, unfortunately. I'll give you a few seconds to jump in and poll on that one.
So I'm just getting most of the votes coming through now. We've had about 70% come through, and we've got about half of people saying migraine, 30% saying diabetes, 14% asthma, and about around 10% MS, currently 0% for epilepsy.
There were just very good guesses, and I mean, asthma, diabetes, both very common conditions, but it's something of a surprise sometimes to introduce to people that, in fact, the most common disorder out of the whole, those headache disorders and migraine in particular, which the prevalence of which varies largely depending on how well it's been studied. So in areas of the world where it hasn't been studied very well, that the prevalence is relatively low, and in areas where there's a greater degree of health literacy and a greater degree of epidemiological studies, the rates are much higher. In fact, in Australia, there isn't a good epidemiological study yet to quote, but broadly, it's estimated to be 1.1 billion people worldwide suffer from migraine, and which makes it the most common neurological disorder. And it's a leading cause of what is termed reversible disability, or disability adjusted life years. And the reason that I really focus on that word reversible is that with effective treatment, we can significantly improve quality of life and limit the impact of the disease. But it's really only if we shine a light on it that we can actually make a difference and improve people's lives. So it's really important to consider and to take an approach to, which probably an unsurprising introduction to a lecture on headache. When it comes to classifying headache disorders in general, so neurologists, GP specialists in your health team, we all follow a particular classification which you might see referred to in your letters and or discussed with you, and it's nice to know where that comes from, partly so we're all speaking the same language. So The International Headache Society is the governing professional body for headache disorders, and they've put out an international classification of headache disorders, which is now in its 3rd edition, and it's an excellent soporific for people who have difficulty falling asleep at night. There's over 100 different headache classifications that are listed in there, which I'm not going to go through. But broadly, you can consider them as different under different umbrellas. So people can have a primary headache disorder, that is, the headache itself is the disorder, is the pathology. And examples of that might be migraine or cluster headache. So you could think of that, it's a little bit like dementia. So dementia is the umbrella term, and then the specific conditions underneath it, like Alzheimer's dementia or Lewy body dementia or vascular dementia. Or there's secondary headache disorders, where headache is something which somebody may experience and or suffer from, but the headache itself has either arisen in part or completely due to another process or another disease. So a secondary headache disorder might be something where somebody experiences a headache which is due to an infection on the brain, like meningitis, or medication overuse headache, where people overuse acute analgesia, which can lead to a second headache disorder on top of another one. And then finally, there's the neuralgia form disorders, which kind of sit off under their own umbrella, for which trigeminal neuralgia is a prototypic example. In terms of headache disorders that are associated with multiple sclerosis, there's several different headache disorders that are associated, but the ones that really wanted to focus on today were migraine, tension-type headache, trigeminal neuralgia, and cluster headache. So migraine, by far the better studied of the conditions. The estimated prevalence in multiple sclerosis is about 1/3 of people, and it varies again depending on the study and the quality of the study, but that's kind of a great excess compared to the general population. So in general, it's between 1 in 5, 1 in 7 people in the general population report a history of migraine. Tension-type headaches, the prevalence gets up to about 20% in some studies, and trigeminal neuralgia between 1 in 10 and 1 in 20 people. Cluster headache sits off a little bit on its own in that it's rarer headache disorder in general, but it's a very significant one in terms of the experience of the pain and the disability that it can cause. So it's really important to mention as well. So, second question for the afternoon. So, if you yourself suffer from a headache disorder or experience a headache disorder, or if you're caring for somebody who has a headache disorder, curious as to what people experience, and you can make a selection there between migraine, trigeminal neuralgia, cluster headache, tension-type headache, or one of the others.
So we've got in most of the votes now. They're coming in very quick. So about half of respondents have said migraine, around 30% have said tension-type headaches, and around 10% each for trigeminal neuralgia and cluster headache, and then about 5% for other.
Right. So not a bad representation in terms of the statistics and what we'd expect on a population level. So we're a small little microcosm. So I'll introduce first of all migraine. So migraine is a complex disorder, and broadly it's considered a disorder of sensory processing now. In the 20th century, it was more specifically thought of as a vascular disorder, but we've increasingly moved away from that the more we've learned about the condition in the last decade. When it comes to a migraine, there are 4 distinct phases to a migraine attack which you may experience. And not the first phase, but the one which is most recognizable is the headache phase, because that's the painful phase. And so it's something which is unfortunately very easy to recognize. It's characterized by moderate to severe pain. For about half of people, it'll be throbbing pain, which can start on one side of the head. It may stay there, or it might spread to involve the whole head. It's particular factors which can often happen with migraine is that the pain may worsen with activity. So if you try and do physical activity, be that you're climbing the stairs, going about your regular day, the pain can often feel like it's worsening as you continue to try and go about your daily life. And The pain can be also associated with either nausea or a sense of sensitivity to light or sound, and that can vary between you notice that the TV is bothering you a bit more to being, I can't tolerate being around other things in my environment and you needing to shut yourself off. So different people will have a different experience from that perspective. And the pain itself will last, in general, between 4 and 72 hours untreated, although it can, for some people, last longer. And that's really what gives kind of the prototypic example of migraine of somebody who's got horrible pain, which gets worse when you try and move, and is associated with nausea and sensitivity to light, which is why people may have a preference for staying still, lying down in a dark room. Outside of the time of the migraine pain, however, you can have a prodrome and a postdrome, so the build up and lead out from the pain phase of a migraine. And this can last for hours to days prior and after the headache phase, which we've recognised. And some of the symptoms which can commonly be experienced here are so increased levels of fatigue, more difficulty concentrating or focusing on what you're doing. And similarly, you can still get sensitivity to light and sound in this phase of a migraine as well. You can also experience some mood changes, as well as neck stiffness and even food cravings, which makes identifying triggers for migraine can be particularly difficult. So we've done, broadly, the research community has done imaging studies on people who are in this prodromal phase. So at this stage, the brain's already on track to have the migraine, and you start to experience some things like food cravings or neck stiffness. And so you have a particular food, chocolate, be it something else, and you go on to have the migraine, and it can lead to this sense of association that the food caused the migraine, when in fact you had the food because you were having the migraine and developed a particular food craving because of it. That's not to say that there aren't people who can identify the particular foods as triggers for migraines, just that it can sometimes be a very complex and two-way relationship. So it's not always that easy to differentiate between, what's been the cause of the migraine and what has been a symptom of the migraine. So the more we've learned, the harder it's got. And then there's the migraine aura. And so about 1/3 of people who experience migraine will also have a migraine aura. And some people will have this with each attack. Some people will have this only occasionally. And some people can have it outside of the rest of the symptoms of their migraine. So they don't get a headache, but they do still get the aura. So anything which the brain can do, a migraine aura can disrupt. But for the majority, for 95% of people, it's a visual symptom. And so the most common examples for this I've got on the screen there. So there's what I lovingly call kaleidoscope vision. So the fortification spectra, which you can see, which often will start in the periphery of the vision and spread slowly throughout somebody's vision over a period of 10-15 minutes. You can also get a scotoma or an area of blurring, but you can rarely get other symptoms as well. So an example there of a sensory aura where somebody might experience some tingling numbness, which starts in the hand and spreads up through the arm. These are important to know that migraine auras occur, and the first time which somebody experiences a migraine aura, particularly if it's weakness or numbness or another worrying symptom, it's not uncommon to either go to the emergency department or to speak to your neurologist or your general practitioner, and that's very appropriate to do if you're worried about a significant pathology such as a stroke, or in the case of multiple sclerosis, a relapse of the multiple sclerosis. Generally, though, this is something which your treating team can work through on history and provide some reassurance. And once we've established that this is a pattern and this is your experience of migraine, it's something which you can help to manage. In terms of, again, from our end as clinicians, when we're characterising migraine, we'll split things in terms of whether somebody experiences migraine with or without aura, and then in terms of the frequency of their migraines or headaches that are experienced throughout the month. So in the case of if somebody's having less than 15 days a month of headaches or migraines, we'll call that episodic migraine. And if they're having more than 15 days per month, then we call it a chronic migraine, which is a little bit different to a lot of other conditions where chronic denotes the length of time that you've had the condition for. Unfortunately, it's just slightly different in migraine, and that's important to recognise because there's different treatments that are eligible on the PBS depending on the type and the frequency of the headaches. So finally, third question. So how often do you yourself suffer from your headache disorder? So it's daily or multiple times a day in case of trigeminal neuralgia or cluster headache? Is it every second day, once a week on average, or once a month or less?
Votes are rolling in. So once a week, it's around 45%. Once a month, around the 25% mark. 15% of people have them daily or multiple times per day, and around 10% every second day.
So a lot of people with once a week or more, which kind of plays into a couple of slides in terms of the management and migraine with MS. So there's obviously the nth detail that we come into in terms of the relationship between migraine and multiple sclerosis, but just speaking, in very broad terms, there is an association between migraine and multiple sclerosis. So having migraine, it in and of itself does denote a very small increase in risk of developing multiple sclerosis in life. The absolute risk of this is very small, but there is a relationship there. And people who have MS and also have migraine, when in studies have been shown that significantly worse scores are reported in terms of role limitation due to physical pain, bodily pain, and even health perception. Despite this, only a third of people with MS and migraine in some international studies have asked their neurologist about specific anti-migraine treatment, and only 10% have started a preventative treatment for their migraines, and even fewer have had a migraine-specific painkiller. So really the point that I want to belabor here is that if this is something which you're suffering from or you experience regularly, here to talk to your treating team about it, to speak to your GP specialist, speak to your neurologist, speak to your nurse specialist. Louise, at one of your previous webinars, spoke about writing a list of things that you want to address at each appointment, and this may be one that may need to make the list, because if it's not something which we report and advocate for, it's not always going to be something which gets asked in an otherwise busy consultation. So we need to know that it's a priority for you. In terms of managing migraines, in very broad brushstrokes, so there's three essential pillars. So there's lifestyle management, and the key parts of this, so sleep. So we're trying to get to bed at the same time, good quality here in terms of sleep hygiene and the amount of sleep, and keeping a regular cycle from that perspective. Aerobic exercise has been shown to be helpful. Maintaining a healthy, balanced diet, avoiding long periods of fasting, excesses of caffeine, keeping a diary so you know how often you're getting your headaches, and so you can help address it at each appointment, and where possible, managing stress and addressing other lifestyle factors. And I usually introduce this as, people who also have multiple sclerosis really have a leg up from this perspective. So part of the rainbow of brain health, a lot of the same messages and same things that are important from a multiple sclerosis perspective also benefit your migraine. So they're wonderful things to be doing. None of it is a panacea. None of our treatments are a panacea, but it's important to have more things working for you rather than against you. Then there's acute treatments, so things that we can do once the pain has started to try and help relieve the pain. The general principle here is that to try and start treatments early and to aim to have relief from pain within a couple of hours, and sometimes using different classes of medications in combination would be particularly effective here. In general, the advice is to avoid opiate-containing medications and to avoid what's known as medication overuse headaches. So if somebody needs to take acute analgesia, in the case of triptans or opiates, more than 10 days per month, or simple analgesia such as paracetamol or non-steroidal anti-inflammatory medications more than every second day, it increases the risk of developing a second headache disorder on top of your first of medication overuse headaches, which can make the treatment a little bit harder. And so it's much easier if we can avoid it in the first place by reducing the number of days that we need acute medications, by reducing the number of headaches in the first place, which is the prevention side. So limiting the burden of the disease by reducing the number of headaches. So if you're having one headache a week or more, it's something which is worth considering as to whether it's impacting on your life enough that you'd want to try and help reduce the number of headaches, or even if there are fewer headaches in that, but each individual headache is particularly disabling, impacting on life, or it's particularly difficult to treat, it might be worth considering. And there's a variety of different treatment options that can be effective for migraine, so it's really important to discuss what's most appropriate and what could be helpful with your treating team. So, question 4, in the last 3 months, or if it's been longer, your last appointment, is this something that we've discussed with your treating team, so either with your neurologist, with your GP specialist, or with another health professional?
Okay, so about 80% of the votes are in, and around half of the respondents have said it's not currently being managed by a health professional. About a quarter it's been managed by the neurologist, about 15% by the GP, and then 8% by other health professionals.
So I suppose, again, to belabor the point, if it is something which is impacting on life, it is worth bringing your next appointment, adding it to your list of things to discuss, because there are effective treatments for migraine and for each headache disorder, but it's something which needs to be raised in order to be addressed, and you're your own best advocate from that perspective. So we do want to hear from you about what's important and what you're experiencing. And on the topic of treatment, this is a very small plug for a colleague who is looking at the moment, working through Alfred and Monash University at one of particular therapy for migraine. So they're looking at the effect of cognitive behavioral therapy, so a psychological therapy, and the impact that may have on migraines and people with migraine and MS. So if you are in Australia and you have more than 3 migraines per month, then they would love to hear from you, and there's a QR code there for your interest. That's something which they're running at the moment. So moving on a little bit quicker through the other headache disorders that we talked about. So tension type headache, which is best described as the featureless headache. So it's the negative of everything that migraine is. So whereas we talked about the headache phase of a migraine in it being kind of typically throbbing pain, can get worse with activity, have sensitivity to light or sound, tension type headache is the reverse of that. So it's a dull pain. People can describe it like a vice or a tight band. But in contrast to headache, to migraines, I beg your pardon, they don't tend to have the throbbing features, they don't tend to get worse with activity, and they don't have the same sensitivity to light or sound which a migraine may have. Now, a lot of people who have migraines will have these kind of slightly more featureless headaches in addition to their migraines, and we would still broadly characterize that as migraine. But there's some people who just don't have a migrainous headache, and they would be the people who we would describe as having more tension type headache. Important to recognize, because obviously different treatments for each headache disorder. But moving straight along to cluster headache. So cluster headache, in contrast to migraine again, where migraine may start on one side of the head and it may stay there, or it might spread to be the whole head, or it might switch sides. Cluster headache is a strictly side-locked headache. So the pain will start on one side, it will be excruciating at its onset, and it's amongst the worst pain which can be experienced, as I understand. And it will stay in that one side. So it's typically over the front of your temple or behind the eye, and you can experience sensitivity to light as well, but it's still on that same side. You might get a runny nose or a flushed face, a red eye, tearing of the eye, but everything is on that same side as the pain. And in contrast to migraine, where people may experience preference to stay still because the pain worsens, or going to a light, to a dark room and avoid movement, people with cluster headache may experience a sense of agitation or restlessness, so a feeling that you need to get up, pace, move about the room, or even just a feeling of inner restlessness along with the pain. And it's kind of a feature which you see more in cluster and not so much in migraine headaches. In terms of the management of cluster headaches, so again, there's kind of three guiding principles. First and foremost, we want to stop the pain. And we want something which works very quickly, because the pain for cluster headache comes on and is maximal very quickly, and typically will last an hour and a half or so. So we want something which works quickly. And different people, different medications are appropriate. So this is very general, but the two therapies that can be most effective for cluster headache are either a quick-acting triptan medication or high flow of medical oxygen. We then want to go on to try and break this current cluster. So cluster headaches will often happen in runs, particularly in springtime, particularly in the evenings. It's just part of its name. And so sometimes a course of steroids, or your neurologist may be able to perform a peripheral nerve block to try and help break this cluster, but ultimately the goal is to start on a medication to try and prevent further clusters and to stop them from coming back. And so the first line therapy in Australia from that perspective is verapamil, but there's certainly other medications also if that is either not appropriate or not effective for you. So we've talked a little bit about having management plans for how to approach different acute headaches. So just as a general thing, do you currently have a plan for what that you've worked through with your health practitioner for how to manage your particular headache disorder when one occurs?
We're seeing about 70% of people saying no and around 30% saying yes.
So even something which we need to do a little bit better as a health professional group, and having that plan of, this is what I know I'm going to do when I start to develop a headache is certainly achievable for in the vast majority of cases, and really gives a lot of confidence if we know what's going to how we're going to work. We know what to do when that doesn't work and when to escalate therapies from that perspective. And it also gives us a great path to come back to at the next appointment in terms of what's worked, what hasn't. And then finally, to touch on trigeminal neuralgia. So trigeminal neuralgia is neuralgia form, so it's a pain in the nerve itself, or being triggered by the nerve itself, which people experience in the distribution of one of the or several of the branches of the trigeminal nerve. So the trigeminal nerve's a nerve which exits the brainstem and then comes out and leaves various spots as it branches out, and you kind of put a picture up there for your interest, but the various branches go to different aspects of the face and part of the scalp. And people who experience trigeminal neuralgia will have a electric shooting, stabbing, sharp, people's description will vary, but pain, but typically will last for seconds and continue to occur a little bit like a sore tooth. Some people will have an underlying continuous pain in the same area of the face underneath those sharp jolts. One of the other features which is common in trigeminal neuralgia is that you can sometimes stimulate, unfortunately, the pain, and it's often very innocuous everyday things like you go outside and you catch a breeze on the side of the face, chewing or combing the hair can all be triggers from that perspective. So if this is something which you're experiencing, this is something which is a bit more common in multiple sclerosis, it's worth mentioning. The first line therapy from this perspective is an anti-seizure medication by the name of Tegretol or carbamazepine, but there's a variety of different medications which may or may not be suitable for your particular. There in your particular circumstance. Whenever we have somebody who presents with them, trigeminal neuralgia will often organise an MRI to look and see if there's a particular cause or something which we can see has been contributing to the condition. In the case of multiple sclerosis, there's sometimes a demyelinating plaque just in the region where the trigeminal nerve enters into the rest of the brain, which can cause to aggravate symptoms. And there's a variety of different treatment options if that doesn't work. So finally, I thought I would preempt things a little bit just by talking about a few of the more common questions which I've been asked over the last year with people who've presented with or been referred on to me with multiple sclerosis and also a headache disorder. The first of which is sometimes, is the headache caused by the multiple sclerosis, or is my current headache a symptom of my multiple sclerosis relapsing? And so as we talked about, particularly with in the context of migraine, so headache disorders themselves, they're very common diseases, and so they can come on in their own accord, and they may become apparent only after the diagnosis of multiple sclerosis. It's very difficult, unless we find a MS lesion which is in a specific spot which we know is going to trigger migraines, to be able to delineate and say, has the MS caused the migraine, or is the migraine something which may have developed anyway but has only become noticeable after the multiple sclerosis? Because the age of that people will present with both conditions is not dissimilar, so either can be true on an individual case. And practically, though, it often doesn't affect our management. So we still want to treat the migraine headaches that you experience, and then our general approach is still very much the same from that perspective. And the second half of that question is sometimes, you're experiencing a migraine at the time. Is this a symptom of your MS relapsing? And so certainly in broad terms, it's true that headaches can be more common at the time of a multiple sclerosis relapse, but it is rare that it is the only symptom. And particularly, we've been increasingly blessed in recent years with more highly effective disease-modifying therapies for multiple sclerosis. This has been much less of an issue. So from that perspective, it's less common, but if you are at all concerned, of course, the most appropriate thing to do is to speak to your treating healthcare team, your neurologist or nurse specialist. As we talked about, migraine aura can disrupt any system in the brain from that perspective, but they are generally transient. They will last 30 minutes to 60 minutes, so they're very different to an MS relapse from that perspective. And so if you're concerned, if it's the first time that you're having something, having a chat and, presenting for your advice is very appropriate. But hopefully once we develop a pattern and we can identify the pattern, we can, reassure that, when you have that, if you have the same symptom again, that it's more likely to be the migraine rather than the multiple sclerosis, in discussion with your team. Secondly, a common question is my headaches being caused by my multiple sclerosis treatment? And certainly it's true that a number of medications can worsen headache disorders. So that's true of certain multiple sclerosis treatments in particular, such as fingolimod and interferon, more associated with it. And we've talked about the regular use of painkillers can increase the frequency of headaches. There's also a host of other medications that can contribute to a headache disorder, and there's examples in every class of medications almost. In general, it's important to be observant about the pattern of your headaches, so that, if you start a new medication, you notice a significant change in your headaches, it's something which you can talk about with your treating team. However, in general, my advice is if you need to be on a medication for your multiple sclerosis, if we're working towards, you having no evidence of disease activity and controlling the disease, and this is the right medication from that perspective, we can generally work on the other end to help manage the headaches that may have worsened as a result of that medication or just in association with that medication. So worth bringing up, but it's generally something that can be addressed if there is an association. And finally, the common one, which either I get or unfortunately people who experience migraines continuously get as well is, is it just a headache? Is it just stress? I can't be any more emphatic than just saying no. Migraine is a complex disease. We haven't gone into a lot of the different things that can occur in the brain at the time of migraine, but it affects the whole brain in multiple ways. And whilst there are various lifestyle factors that can contribute, the easiest way to consider this is that it's a little bit like a threshold disease, that there's things that in your life will make it a little bit easier or a little bit harder to trigger a migraine, but unfortunately, if you suffer from migraines, if you experience migraines, it is something which the correct genetic makeup to put you at risk of, and individual things may make it more likely or less likely, but it's rare that it's always one thing, and that if we removed that one thing, you wouldn't have migraines anymore, unfortunately. In terms of resources, so there's several patient advocacy and information support groups for migraine and for various headache disorders. The second two links on the page there, as well as the professional organisation, the Australian New Zealand Headache Society. All of them have varying fact sheets, resources, information with regards to resources in your local area. And so I'd encourage you to seek that out as you please. And I think we've left some time for any questions.
Yes, I'm back. Thank you very much, Jason. That was very enlightening. And we certainly do have some questions that have come through. So thank you for those that have sent them through. I will say them in order of when they came through. So the first question I had was, what are your thoughts on medical marijuana for headaches?
It's a really good question, and it's an interesting area which there's some ongoing research in. The last time that I did a really proper stretch through the literature, I think that there's some theoretical reasons that you might consider it could be a helpful treatment, but the approach that I take with my patients is that we try and restrict ourselves to areas where we've proven the evidence and we've shown them to be beneficial, and outside of that, we restrict our advice to we don't have enough information yet. And the last time that I read that's where the medical marijuana sat for me, was that we don't have enough good evidence to show that it is an effective and safe treatment to recommend it as a treatment for the majority of patients. But there are certainly practitioners around Melbourne, around Australia, who will recommend medical marijuana in the case of headache disorders. And so there's some individuality in that practice.
Great. So next question. This is just a personal situation, but I have headaches together with fatigue and nausea. My neuro suggested just taking Panadol for 3 months. I don't think that I could do this, or it couldn't be possible as I couldn't function. I currently take 2 most days. What else could I do?
Yeah, so difficult to give specific advice. So it's worth going back and having a chat with your neurologist or with your general practitioner. In general, if you're having frequent headaches, then it would be important to address and to look and see whether there's a preventative medication that we can start to try and help reduce the frequency down of the headaches. In general, you consider paracetamol to be an acute treatment, so something to take within safe dosing when you had a headache as a treatment to try and help lessen the pain, but it wouldn't necessarily reduce the frequency of the headaches themselves and prevent the next one from coming. So that's really the goal of the preventative side of treatments.
Can you have headaches / migraines as part of trigeminal neuralgia, or are you saying that neuralgia is a headache itself?
Yeah, so I mean, trigeminal neuralgia is its own headache disorder, so it sits a little bit off separately in the classification, but it still is a headache disorder. And certainly just because somebody has one headache disorder doesn't unfortunately preclude us from having a second or a third. So it may be that you have two different headache disorders which each require their own focus of treatment and their own strategy for the different type of headache that you might experience on a separate day. So, but certainly there are people who will have multiple different headache disorders.
Cool. Next question. Is it possible to have nausea without a headache, but it be an ongoing migraine?
So it is rare to have nausea as the only symptom of migraine. If that was the case, you'd want to be considering, what else may be contributing and exploring down other diagnoses. So it's certainly to the classification, it's not recognised as that, it's purely migraine if all you're experiencing, not to say all you're experiencing, but if your symptom is nausea and without any other features of migraine, it certainly wouldn't meet the classification. And so in that setting, it's really important to have a detailed discussion with your treating clinician as to what other things we've considered and what's led us to that as a diagnosis. So it's much more individualized from that perspective.
And there's just a question about apps that you know of or that you might recommend for people to track their migraines or their symptoms?
There are a number of apps available on the various devices to help from that perspective, and there's, the name's escaping me as I think, but there's a period tracker app which I've seen people use very effectively, and also to manage their migraines. There's a migraine buddy, I think was the name, and they each have their various advantages and disadvantages in terms of their layout, the type of information, and even how much information they want. For my end as a clinician, what I'm most interested in is the number of days you've had a migraine, a headache, whichever particular headache disorder that you have, the number of days that you've needed to treat them because they've been impacting on your life. And so for the majority of people, something as simple as that on a list on a piece of paper, or the very simple versions of the app is what's most important. So we want it to be simple enough that you feel like you can do it each day without, or each time you have the headache without being too burdensome on your life. So there's not one in particular that I think is better than the others, but certain people gravitate towards one or the other, and we'll work with whatever works for you.
So someone's asked a question about, she says, I have daily headaches with migraine every couple of weeks, and I find it hard to describe my type of headache and any triggers. Is this common? I feel like I should be able to describe or understand my pain better.
Yeah, no, it is very common, and the more frequent migraines become, and particularly once it gets to become chronic and daily headaches, which is it is common. It's not just you. 3% of the population have chronic daily headaches. The more chronic it becomes, the harder it is to identify anything that's been a particular trigger, or even a lot of features which you may have noticed earlier on in life in terms of the distinct phases or features of your headaches really get lost once the headaches get to each day. So that's very common, and it's unfortunately part of the experience of people with migraine. So it's still, from our perspective, it's we focus less on the character of the individual headaches and more about trying to reduce down the frequency overall in that case.
And we've just got one final question that's come in. What can be done about headaches that are triggered by weather?
Unfortunately, not a lot. I don't want to recommend everyone to move to Queensland. I think they've got enough of an issue with the property market after everyone in Victoria moved out there. But No, unfortunately. So whilst in the case of cluster headache, sorry, not to be too facetious, cluster headache has, for a lot of people, a seasonal variability. So we, for some people with cluster, we will expect it each spring, and once we've identified that pattern, it can become something which we target in. So if we know that expecting a cluster to develop in September, we can start in August, for example, to start on a medication such as the Verapamil, which has previously been effective, and build up to a dose that we know is effective, and just try and preempt that from coming in the first place. So in the case of something which has that sort of seasonal variability, it's something which we can try and build a management strategy around. In the case of somebody who experiences migraine and has more likely to have an attack on a day when there's a low cloud or a storm, or what is variably people may find a trigger. Unfortunately, there's just, particularly in Melbourne, due to the lack of predictability of the weather, there's not a particular approach we can bring from that perspective. And so it becomes a matter of having a good management plan to try and help address the pain once the headache has started.
Perfect. Well, thank you for answering all those questions, Jason. I might take over control again now that we've got through them all. Let me just do that. I'll change presenter, share screen. So I'll just now run through a couple of slides at the end, and then we can let you all go and you can eat your dinner and sit in front of the TV or whatever else you might be doing tonight. So I just wanted to run through a few services quickly. We do here at MS Plus offer a number of different services that can help and can support you in your MS journey. So please do, if any of these services do sound like they might be of help, please do give us a call at Plus Connect or email us. So I'll just run through a couple. So for exercise needs. We have Plus Exercise Physiology, we have Plus Physiotherapy as well, so reach out there. We can help with diet and nutrition if that's something you're looking for. Plus Education, which is, this is Plus Education is what's bringing this webinar tonight, so please head to the Resource Hub and have a look through our back catalogue of webinars and podcasts and written materials. There's a lot of good stuff there. So what else do we have? You could probably have a look through those yourself, and you do have the slides. So yeah, I invite you to have a look through those services, and you can head to our website as well, which will have more information. As I spoke about earlier, Resource Hub, that has the webinars, podcasts, articles, and they're all there. You can probably see from that photo there. You can sort through by resource type and by topic, or you can type in keywords. So I invite you to have a look through those. There's plenty of good resources there, and we've covered most topics. And if we haven't covered a topic and you're really interested in, please do write it to us. We asked you to do a survey at the end of this webinar, so please add that in there, because we're always looking to cover more topics, and you're the best people to tell us which we should cover. And as I spoke about earlier, Plus Connect is sort of the gateway to all of the services, anyone that you need to speak to. So you can call us on that number there, 1-800-042-138, or email us at that email there, and you'll either get someone or get a response very quickly. So they work very hard, the Plus Connect team, and they're very knowledgeable. So please do ring up with any queries or concerns, or if you're looking for any support. And finally, I just want to say a massive thank you to Jason. He's been wonderful, super insightful webinar, and I'm sure you all learnt a lot today. And headaches and migraines are a horrible thing, and the more support and help you can get, the better. So Thank you to Jason, and yeah, have a great night, everyone.
Thank you so much.